cancer. My talk isn't a data talk. It's more of a story about a grassroots efforts to use data and physician leadership to improve the care of patients with prostate cancer. And so this will be a slightly different type of talk than what you've watched, and obviously following Jim and Adam at a prostate cancer conference is always a little bit daunting. And so I'm going to tell you the story of the PERC Collaborative and how we're using this to improve the care for patients with prostate cancer, both in Pennsylvania and in New Jersey. So I'm going to talk a lot about physician leadership and performance measurement and how sort of a rising tide can lift all boats with regards to comparing outcomes in a transparent way amongst your peers and using that to improve quality of care. And so PERC is a physician-led prostate cancer quality improvement collaborative. It involves performance measurement, reporting, and real-time risk-adjusted data being fed back to physicians and hospitals. It's based on the Music Collaborative. If you're not familiar with music, all the urologists in the room certainly are. Music is the exact same effort that was done in Michigan that served as the template for what we've now accomplished in Pennsylvania and New Jersey. They have what they've been able to achieve in that state, not only for prostate cancer care and urology, but across about 17 or 18 different surgical subspecialties, is really what I think will happen across the country moving forward. And I'll show a few slides about what they've accomplished in that state through their work with the Blues. The objectives of our collaborative, and I'll get into more detail about this, but it's really to reduce the variation in care and utilization of services between physicians. It's to measure, understand, and influence outcomes following treatment. Ultimately, improving patient-centered decision-making is probably the most important objective that we have. And the way that we do that is we provide a reliable, sustainable platform for data collection with real-time feedback for benchmarking and practice-level quality improvement initiatives. So it's basically making all this data available to the physicians in a transparent way that's non-competitive and allows people to see how they're performing compared to their peers, with regards to sort of best practices. So the PERC program highlights physician leadership and engagement. I'll explain how physicians participate, but active participation is the key for this being successful. We leverage the music experience, and Todd Morgan, who's going to speak after me, participates in music, and we have a very close relationship with them and share data back and forth. And again, they were very instrumental in us sort of exporting their model in a successful fashion. We have a web-based data registry that allows data abstractors for each site to put data in real time. And all of this is sort of possible through the work of the Coordinating Center, the Healthcare Improvement Foundation, which runs by Claudette, Brett, and Sita, who are here today. Again, you're going to see a lot of slides that have the term physician engagement on it, but this quote sort of highlights that safety and quality will improve when physicians are engaged and committed to the system in which they work. Really, the premise of our collaborative is that if physicians want to take on the challenge of improving quality, they have to jump in feet first. They can't let people tell them how to practice. So why have we focused our efforts on prostate cancer? Everyone in the room knows it's the most common cancer in men in the U.S. It's the second leading cause of cancer-related death. From a quality improvement sort of premise, treatment patterns for prostate cancer are rapidly changing, which have been highlighted in the first two talks. The cancer care is costly and it's highly variable based on the type of treatment that you employ. There's not a lot of level one evidence for guideline development, and so if you go to a radiation oncologist, you're going to get radiation. If you go to a surgeon, you're most likely going to get surgery. And there's not the clinical trial evidence to sort of drive best practice. And currently, at the regional and the national level, there's not a lot of data collection and benchmarking on treatment outcomes to inform improvement efforts. Now, through Music's collaborative and our collaborative, there have been some advances at the regional level. At the national level, through the American Urological Association, there's the AQUA registry, which many urologists are participating in. So we're starting to do better. But for the most part, most physicians sort of provide treatment in a vacuum, and it's hard to know how you do compared to your peers. So these collaboratives are based on trust, transparency, sharing of data, and collaboration. And so the way that we work in our collaborative is that the leaders work to develop and execute program activities. There's a clinical registry that collects more than 90 variables about patient risk status, processes of care, and clinical outcomes. The entities that participate, whether it's a hospital or a practice or the individual physicians, receive regular feedback on performance from the coordinating center. It's important to point out that this is confidential and de-identified. At both the individual practice sites and at the collaborative level, we convene regularly to review and interpret the data, and then best practices are identified and implemented across the region. And so it's important, again, to point out this is an easily exportable model that's independent of region or specialty. I mean, I'll be very frank. We copied what music did, and it was very easy. So what are some barriers to doing this type of work? It can't be perceived as a single organization's initiative, and so, I work at Fox Chase. This is not a Fox Chase project. This is a Healthcare Improvement Foundation project, and the benefit is really to everybody that participates. There's always concerns with how data will be used, and very few hospitals or practices or physicians want to give up their own data. Everyone's very happy to look at other people's data. It takes a lot of time to participate. It's time away from your practice and your family that's not financially reimbursed. It's more work. I think physicians are also reluctant to be transparent with their data when there's a payer involved, and we receive a lot of support from Independent Blue Cross. And then to actually collect the data is costly. There's clinical abstractors at each site. It's usually about a quarter to a half of a full-time equivalent, and that translates to about $50,000. So again, for physician engagement, this quote, physicians owning the most optimal way in which healthcare is delivered so it's focused, smooth, effective, and achieves desired patient outcomes. That's sort of a nice way of thinking about it, but it's not really the way most physicians practice. So when we were sort of coming up with our pitch to go out to these practices to start getting people to participate, we had to sort of identify what are the problems that we're trying to look at here. So when you go out to a practice and you're trying to get them to provide their data to you, essentially for free or to pay to do it, it has to be something that they care about. So it needs to be generalizable and relevant to their practice. It has to be current, and it has to be actionable. So collecting data on something that you're not going to drive change with is pointless. And then from the participant perspective, they need to be interested, they need to think that it's relevant and that they're part of something bigger that's going to improve care for their patients. And that sort of offsets the fact that there's the burden of data collection and the costs, because again, at the very, very basic bottom of all of this, improving patient care is the whole reason why we participate. There needs to be support. If it costs too much to participate, no one will want to do it. And so Independence Blue Cross and Partnership for Patient Care really sort of let us get off the ground. You need to take away the logistical barriers to the data collection. And so again, with this web-based platform, it's very easy for entering data. It's all HIPAA compliant. It's all IRB approved. And then from a leadership perspective, not so much for the work that I do or the head of the collaborative, who's Rob Uzo. It's the physician champions who sit on the executive committee that are all well-known urologists or urologic oncologists. The nice thing about urology is that for the most part we all know each other, and it's a non-competitive, non-threatening culture. And so, this is anonymous, de-identified data that is sort of freely available to everybody, and it's not a competitive thing. In terms of organizing sort of what we do with the data, the coordinating center, who's responsible for the day-to-day management, the Healthcare Improvement Foundation has a lot of experience with quality improvement. They provide continuous feedback to the practices so participants don't lose interest or feel that they're not doing anything with the data. Everybody who participates and submits data to the collaborative has a voice in what we're doing. And by everyone participating and deciding which topics are important for quality improvement, I think it keeps them vested and makes them feel like they're, again, participating in something bigger than just their practice. So we're not the first to think about physician engagement. There was a Brigham study that surveyed 10 high-performing U.S. hospitals to determine how best physicians can be engaged in safety and quality, and they came up with a 6-point framework incorporating engaged leadership, physician agreement, appropriate compensation when possible, realigning their financial incentives, data collection, and then promotion of the work they do. And so as you're trying to bring these groups of physicians together, you have to realize that the outcome can be obstructed when financial incentives emphasize individual productivity. Centralized decision-making has been found to dampen levels of physician loyalty, and medical staff members who are overwhelmed with competing priorities are often skeptical of additional improvement projects. And so again, physicians being in the room together, talking about sort of how best they can utilize their energy for this is the key to it being successful. Other barriers to physician engagement. On the cultural side, really from the institutional level, I mean, you know, especially in a city like Philadelphia where a lot of these practices are located, there's a lot of competition between these groups, and so there's a reluctance to share data simply for that reason. For the personal level for these physicians, most doctors think they know what they're doing and don't want to be told how to practice, and so there's always a suspicion when there's a sort of larger entity telling them sort of what's best practice they should follow. Logistical, as I mentioned before, from a time, paperwork, additional administrative responsibility, that's always a barrier for physicians who work a lot at baseline. And then, again, as healthcare, becomes more centralized between institutions and the dollar gets tighter, providing money at the institutional level for quality improvement collaboratives such as this can sometimes be a big ask. And so ways that we try to improve, or not improve, but ways that we try to harness physician engagement is that we make each clinical champion know that their voice is as important as everybody else's. We identify physician champions for key initiatives. We ensure that the practice patterns we focus on changing support cost savings over time. And then what we really try to do best with this is use the data that we collect to support changes in behavior. So again, getting back to music, which serves as the template for the work that we've done, this quote is from Jim Monty, who trained David Miller, and the two of them are the ones that sort of went out to practices in the beginning and got the majority of the state of Michigan to participate in this. And when asked, why would people participate in music, he said urologists were anxious to do something positive, be proactive, rather than a negative reaction to all the assaults on patient cares and providers. Again, I think physicians are more vested when they feel like they're determining how they should practice, not being told by somebody else, whether it's a hospital or a payer group, how they should do it. And just to emphasize how this can ultimately save money while improving care, Blue Cross Blue Shield of Michigan has been very supportive of these different collaboratives in the state of Michigan, more so than probably anywhere else in the country. I'm sure Todd could correct me, but I believe there are 17 or 18 subspecialty groups, collaboratives like this, and they estimated in 2014 that they had saved close to $600 million statewide over a 5-year period. Now, dollars in healthcare is a very nebulous term, but what these value partnerships show is that these programs shine a spotlight on how doctors and hospitals, in partnership with a health plan, so it's doctors, hospitals, and payers all working together, can transform healthcare by sharing data and improving patient outcomes in their practices, and that's a good thing. So the core principles of the collaborative, which are very similar to music's, is that this is meant to be collegial and non-competitive. So you're not able to take your outcomes and put them on a billboard and say that at Fox Chase it's better than at Penn or something like that, based on the data that we collect. It's meant to be evidence-based. It's meant to be confidential from outside entities, but transparent within the collaborative. We want the data to be actionable and to focus on effectiveness. We do not want there to be secrets within the collaborative. Again, transparency is the key to people feeling like this is a safe thing to do. And ultimately, we want this to make a contribution by improving quality of care. The governance. So Rob Uzo, who's my boss at Fox Chase, serves as the executive director. He oversees the collaborative activities. My function is the regional clinical champion. What that means is that I am the go-between between the coordinating center and the different clinical champions at each of the sites. So I did a lot of the recruiting in the beginning to bring practices on. We have an executive committee, which is composed of the practice site physician champions. There's one representative from each practice that comes to these quarterly meetings. And what the clinical champions do sort of in concert is direct the QI initiatives, choose the outcome measures that we want to collect, help define how we're going to collect them. They oversee the project managers and data abstractors at each of the sites, and they participate in quarterly meetings and conference calls. And so, again, it's a lot of effort outside of their normal day-to-day activities, and they have to be vested to want to do that. And so I've been very fortunate in working with a lot of great people who take time out of their schedule to participate in this. The coordinating center works with the collaborative leaders to develop and execute the program activities. They provide data training and support to individual practices and providers. They perform practice-specific audits to ensure data integrity. They communicate and coordinate the program meetings. They serve as the liaison between music and PERC. They set the budget. They do all the data analytics and reporting. And they supply encrypted, de-identified data files for research. And so Claudette and Brett and Sita, who do this amongst managing several other QI projects, I mean, it's quite a lot of work. So ultimately, what's the value? So when, what the pitch when I go out to practices to try to promote this? PERC leverages physician engagement to provide unified regional efforts in quality improvement. So it's a way of getting lots of people at the table to figure out how best to take care of patients. It utilizes the clinical registry as a practice management tool to trend and benchmark performance regionally and nationally. Ultimately, we hope that this will fulfill practice level reporting requirements and be better positioned for future Medicare reporting and pay-for-performance incentive plans. This allows your practice to demonstrate regional improvement in outcomes and value to both payers and regulatory agencies. And we've recently applied for and gotten the ability to do American Board of Urology Lifelong Learning Credit for physicians. This slide shows the practices that currently participate in PERC. Our original pilot, or cohort 1, was funded by Partnership for Patient Care and matched by Independence Blue Cross. And that was Albert Einstein Healthcare Network, Fox Chase, and our parent organization, at least now, Temple, Jefferson, Penn, and then a large private practice group, Urology Health Specialists. About a year later, we brought on Geisinger, Penn State, and MD Anderson Cooper. And then we currently have verbal commitments from UPMC and the Cancer Institute in New Jersey to join, hopefully before this calendar year ends. So we currently capture data on anybody undergoing a prostate biopsy and then anybody diagnosed with prostate cancer. We don't capture much radiation data right now, so it's primarily active surveillance and those undergoing surgery. But we currently have 9 practices, 98 participating urologists, and we've collected probably now close to 9,000 cases in a 4-year period. So there's an abundance of data that we've managed to accrue in a very short amount of time. We have executive meetings 3 times a year. They rotate amongst each practice site to encourage everyone to participate and to go. The attendees at these meetings are not just the physician champions and the governance, it's the data abstractors come, we invite our colleagues from our respective practices, and patient advocates as well, really to try to get a sense for, in each person's practice, what are the most important topics that they feel are necessary for quality improvement. The discussions that are had there involve the development and dissemination of improvement strategies and best practices, identify specific care processes that are associated with better patient outcomes, and then again review the work that we're doing and the deliverables that we're providing to ensure that we're supporting their participants in their time. These meetings also allow us to present, have the different working groups through the collaborative present their data. This way we're able to analyze and evaluate regional patterns of care and treatment outcomes, and then identify unwarranted variations in care and outcomes that can serve as the focus for the different QI initiatives, and I'll show some slides on that coming up. Also, the coordinating center provides practice-specific data reports, a report card, for lack of a better term, that shows your volumes. There's a biopsy report card showing antibiotic utilization, sepsis, complications, and then the champion report for prostate cancer, which shows imaging utilization, active surveillance data, and prostatectomy outcomes. And that's something that each practice can bring back to their respective partners shows data both within the collaborative itself and then the individual providers within each practice, and allows you to see how you're doing and respond to sort of how you compare against your peers. We have 4 working groups currently. We have an active surveillance working group that's chaired by Adam Reese, who's a colleague of ours at Temple. There's a prostate biopsy working group chaired by Thomas Lancioni from the private group that participates, Urology Health Specialists. An imaging working group chaired by one of my former fellows, Serge Ginsberg, who's the head of urologic oncology at Einstein. And then our most recent working group, which is the genomics working group, is chaired by Jeff Tomaszewski, another former fellow of ours who's at MD Anderson Cooper. So just to highlight some of the work that they've done, which is, again, is extra work sort of in their free time, the goals of the active surveillance working group are to increase utilization for very low and low-risk prostate cancer patients. The nice thing about collecting this kind of data is we can characterize real-time practice and patient compliance and provider compliance with follow-up. So, for example, people on active surveillance should be getting restaging biopsies, should be getting MRIs, should be getting PSAs, but we don't really know outside of tertiary care experiences how that's being done. This provides a mechanism for getting that data. And then one of Adam's interests is in examining racial disparities in active surveillance utilization, and so he presented some of that data at the AUA, and he's in the process of publishing it right now. We're also partnering with Music, and we may do a pilot implementation of their active surveillance roadmap, and that's something we have talks about doing in the future. So just to show how this data can be utilized in sort of a proactive way. The top bar graph shows active surveillance performance in low-risk prostate cancer patients by each of the different practice sites. And so overall, 54% of low-risk patients in PERC undergo active surveillance, and I think that's good. It's not perfect. It should be higher. But I think what this also really highlights is that at one end of the spectrum, at one practice, close to 90% of those patients undergo active surveillance, whereas on the other side, only a third of patients undergo active surveillance. And so that shows how much variation there can be just within one region, which is really about just 2 states. The bottom graph, excluding physicians that have entered data on less than 5 patients, shows at the individual provider level, and here the variation is even more extreme. Some providers perform active surveillance in 100% of low-risk patients, as opposed to some that do it about 10% of the time. And so I think this is really where, when someone's presented with their data, they know where they stand on these different graphs. It allows them to sort of think about the way that they practice and maybe how they can make changes. What this slide shows is just in the 2-year period how sort of, whether it's Hawthorne effect or not, bringing attention to this data has increased utilization of active surveillance among the low-risk population by about 10 to 15%. The biopsy working group, again headed by Tom Lancioni, their goals have been to reduce variation in antibiotics prescribed prior to biopsy. They're exploring sort of the utility of different rectal installations before biopsy, and then with the ultimate goal of lowering the sepsis rate. And we've developed a best practice antibiotic measure that we feel is consistent with the AUA guidelines. I think this is, again, a slide really just designed to show the extreme amount of variation between practices. The top graph shows the most common antibiotic combinations, but overall there were 75 different antibiotic combinations being utilized by these practices before something as simple as a prostate biopsy, which basically shows that in urology you can basically do whatever you want, and it doesn't necessarily follow best practice. And so our goal is to take those 75 different combinations and then, with some guidance, get it down to 3 specific antibiotic recommendations. And that was use of either a fluoroquinolone, a cephalosporin, or gentamicin. And so I think, again, this provides sort of an educational opportunity for providers who maybe have been doing these procedures a certain way for 30 years, that there are guidelines that they can follow. And again, in the era where antibiotic stewardship is so important, and ultimately this may go away if transperineal biopsy really takes off, and I know we're starting to do that too. I think this gives physicians, a chance to reflect on the way that they practice. And so, this also provides an example of how we can use the data to sort of direct our attention best. So what this slide is meant to show mainly is that sepsis rates in the collaborative are fairly low. It looks like sepsis rates are going up sort of at the tail end of the graph, and that's probably just because of better data collection. But what this caused us to look back on is if you're trying to impact something that happens less than 1% of the time, maybe that energy can be used to focus on something else. The imaging working group, which has been headed by Serge Ginsberg, this working group probably has the most concrete goals of the collaborative. The first were to decrease bone scan and CT utilization in very low and low-risk patients. And the purpose of that is those are PQRS measures, reportable measures to Medicare that every practice is supposed to report back already. And so this is a way of showing how we can collect that data and take on that administrative burden for practices. And they're very concrete things that payers care about. And there are also, one of the focuses is to increase imaging utilization in high-risk patients where it's appropriate. So through a fair amount of work, they've developed some new metrics, imaging appropriateness criteria. We're collecting very granular data on utilization of MRI, both in the pre-biopsy setting, active surveillance setting, surgical planning setting. And again, that's real-time data that's not readily available in most data sources, outside of music or maybe ultimately Aqua. And then getting this imaging appropriateness criteria out to the different providers. The way that they've done that is with pocket cards, highlighting recent changes in the AUA guidelines. And so this, again, I'll give an example. My senior partner, who's been doing this for about 30 years, still orders a bone scan and a CAT scan on every patient that comes in. And this is a way of showing them that's probably not the right thing to do. So I think this is also where we've shown the best that we've been able to move the needle. Over a 4 or 5 year period, we've really seen rates of bone scan and CT scan utilization for the very low and low risk population drop. And this is something that when we go to IBC to prove our value, this is the type of work that we can show that this is a cost savings and, following best practice, improving quality of care. Another slide highlighting the variation between practices. Top slide is a bone scan when not indicated. So ordering a bone scan for low-risk disease. Some practices perform very well. Some practices still order these tests in more than 50% of cases when they walk in the door. Overall, as a collaborative, it's about 30%. I would argue that that's not very good and that we can really improve that. The genomics working group, this is the one that personally I'm the most excited about and I participate in, which is led by Jeff Tomaszewski. Genomics is sort of a black box right now that's a rapidly evolving space. I'm sure Todd could comment on this much more elegantly than I can, but there are new tests coming out all the time. The indications for each of the tests are rapidly expanding sort of as they try to compete within a very narrow market. And so our goals of the genomics working group is to accumulate robust data regarding real-time practice utilization, understand who's ordering the tests and when, and is it being done appropriately, providing educational materials to decrease inappropriate test utilization because they can be quite costly. And we've developed a number of utilization measures so we can track this across the collaborative. This is, again, just to show that some practices use this in more readily than others. And again, these tests can be ordered in so many different settings that it's hard to show one graph of appropriateness or inappropriate use of these testings because it can be used in the pre-biopsy period, post-biopsy period, pre-surgery period, and post-surgery period. We've utilized the collaborative to do a number of surveys to understand how patients are currently practicing and using that data to sort of drive the agendas for the different working group committees. So we've done one on, again, practice and utilization of prostate cancer biomarkers, and what came out of that survey is that we saw so much disparity between providers that we really felt like an educational intervention was required, so we can disseminate materials to improve the efficiency and reduce inappropriate testing, and then also just illustrating the cost and insurance coverage for the most commonly utilized biomarkers so physicians had ready access to it if they weren't familiar before. One of our first surveys was on antibiotic utilization and the different methods of prophylaxis prior to biopsy, and that led to developing a best practice antibiotic measure in compliance with our national guidelines and then giving recommendations to the practice with regards to what antibiotics we felt were most appropriate. And we're currently reevaluating sort of how, if we've been able to narrow that number of 75 different ways of delivering prophylaxis, and so we want to trend that over time and see if we've improved. And then Finally, we did a survey on understanding active surveillance as a treatment for men with low-risk prostate cancer. And again, through collaborative work with music, potential collaborative work with Memorial Sloan Kettering, we're trying to use the collaborative as a mechanism for really evaluating and implementing active surveillance in a greater proportion of our patients. There is an academic component to this as a way of helping keep people vested and to use the data in sort of a productive way. And so we have not been nearly as proliferative as music, but we've presented our data at a number of meetings at this point, and finally have some publications going out, and the data has matured to a point that it, I think, is finally sort of usable for research purposes. And when you're talking about utilizing this type of data, both for practice reporting and then also for research purposes, you know, garbage in is garbage out. And so one of the most important jobs of the coordinating center is that they do on-site quality visits in which they compare the registry volume to billing reports to make sure they're adequately capturing all the patients that should be entered. They do random chart audits to verify the data accuracy. This also provides sort of a face-to-face opportunity sitting down with the abstractors and the clinical champion to identify issues that they're having with, you know, do they understand the variables? Can they find the data in the chart? What are ways that they can streamline these processes to make it easier for them? And then ultimately they review the quality data with the physician champion and the executive committee to identify areas of opportunity, you know, both for easing the administrative burden and making this a higher yield process for each site. So to sort of wrap this up, you know, this has been a 5-year effort. It's been personally very rewarding for me, working with each of the different physician champions in HCIF and sort of getting this off the ground. We're finally starting to show that we're moving the needle, reduction in inappropriate testing, increasing utilization of active surveillance. These are all very good things. These are things that, like, we can, as a collaborative, can feel proud of. But it also gives us a way of demonstrating to the people that fund us that this is, you know, a productive use of time, and it's something we can show practices that aren't participating yet that this might be something that they want to be part of. It also provides an opportunity for community outreach, and so through a lot of work, mainly by Claudette, we've received grants funding prostate cancer awareness projects, offering free PSA screenings in North Philadelphia, which has been funded by the Pennsylvania Department of Health. Additional activities include prostate cancer awareness projects that have, you know, provide an opportunity for collaboration between primary care providers and urologists, inform decision-making tools for patients that are interested in screening, and gives educational checklists for providers. So to summarize, why is collaboration important, and how can it best be utilized? I mean, it's all based on, again, physician leadership, sharing of data based on transparency and trust, you know, not operating in a vacuum, understanding variation in clinical care and how that can be used to improve patient outcomes, and then to identify and implement best practices across the region. If physicians operate in a vacuum, they're not going to improve care. Working with your peers is the best way to do that across, you know, even a large geographic area. Our next steps as a collaborative is we're identifying best practice bundles. We're putting together these educational materials on genomics and biomarkers. We're developing active surveillance guidelines and a roadmap for patient decision-making, examining racial disparities in care, continuing to improve biopsy practices, and benchmarking with the Music Collaborative. There's a bunch of people to thank that are present here at the conference. There's participants from Hershey, Suzanne Merrill and Jay Rahman are here, Kathy Lehman. From the Pennsylvania Prostate Cancer Coalition, Jim Williams and Christine Warner have been wonderful in working with us and providing us with this venue for speaking today. Todd Morgan, who you're going to hear a great talk from next, participates in music. And then Eric Gorman and Sharon Sowers from the Pennsylvania Cancer Coalition and the Department of Health. And then all of the people at Healthcare Improvement Foundation who are the engine that drives the collaborative, Claudette Fonchelle, Brett Marlowe, Sitha D. I mean, they do the majority of the work that allows us to do this. If there's any questions, we can be reached at the coordinating center on the number that's provided. I'm always happy to get an email, and I'm happy to give my phone number out to anybody that's here. And then also you can email Claudette Fonchelle. Anybody have any questions about any of this?